This video shows an innovative navigation system for the guidance of endovascular procedures developed at Endovasc, a center for computer-assisted surgery of the University of Pisa. The proposed system offers a complete 3D visualization of the surgical field during endovascular navigation, and it allows a significant reduction in radiation and contrast medium dose. The navigator includes sensorized catheters and guidewires simultaneously tracked with an electromagnetic localizer. The proposed electromagnetic technology is safe, reliable, and already used to guide surgical procedures. As a demonstration of the proposed concept, here you can see a traditional Cobra catheter integrating two electromagnetic sensors, which allow the real-time tracking of the catheter distal part, represented on the screen by the blue structure. Moreover, you can also see a yellow cylinder representing the distal part of a sensorized guide wire that advances beyond the catheter tip. This sensorization strategy can be applied also for the real-time tracking of steerable catheters to infer the deformation of their distal curvature. Selected electromagnetic sensors can be embedded inside the endovascular instruments, thus ensuring water and blood resistance. For navigation purposes, EM data, instruments position and orientation are currently merged with an accurate 3D description of the patient anatomy. The 3D model can be extracted from preoperative radiological images such as CT or MR dataset or intraoperative 3D rotational angiography images, which are elaborated with rendering techniques to visualize the model of the vascular anatomy. The following videos show examples of the 3D electromagnetic navigation concept during in vitro navigation tests. This is one of the simulators we use for our tests. It is an ad hoc made simulator with a patient-specific replica of an abdominal aneurysm. The aneurysm model was fabricated starting from the elaboration of real radiological images. In particular, CT images were segmented to extract the 3D model of the patient aorta, which was then fabricated in plastic material with a 3D printer, and finally was embedded inside a pelvis model. Just like in a real procedure, the 3D model of the simulator was acquired with a 3D rotational C-arm. The acquired model was imported into the Navigator software and used as a 3D map for the electromagnetic navigation of catheters and guide wires. As you can see, the operator can rotate the 3D scene to get a better visualization of the anatomical model and the endovascular instrument. In vitro tests were also performed on abdominal aortic aneurysm model connected to a continuous pump for circulation of water. This is the corresponding 3D virtual model imported into the Navigator software. An interesting possibility offered by the graphical user interface is adding or removing arteries in function of the surgical task. Moreover, during the navigation, the system allows the user to select an optional virtual endoscopic view, aligned with the catheter tip. This view can be particularly useful for cannulation tests. In vitro tests have proved the system accuracy, usability, and effectiveness. Published works report an evaluation of the system maximum and mean error and prove the efficacy of the navigator to guide endovascular procedures. Results of in vitro tests indeed show no significant differences between using the traditional fluoroscopic method and the EM navigator as for operators' performance. Finally, the system can allow the development of innovative procedures, such as the in situ endograft fenestration for endovascular aneurysm repair procedure. The most important limitation to the application of the endovascular aneurysm repair is an unsuitable proximal implantation site, in particular the lack of a suitable length of proximal neck, the earthy vessel portion between the aneurysm and vital branches, where to anchor the prosthesis. Fenestrated grafting, the traditional patient-specific solution for the endovascular repair of unfavorable aneurysm, is technically challenging and requires long fluoroscopic exposure times. Customized grafts are also expensive and not available for acute syndrome. For these reasons, alternatives such as the in situ fenestration of a standard endograft have been proposed. To date, the trustability of this procedure, especially for abdominal aneurysm, is limited by the lack of a safe method to perforate the graft and the difficulty in identifying the fenestration site. After the endograft deployment, the contrast medium does not flow inside the collateral arteries, which thus cannot be angiographically visualized. An interesting solution can be the development of an electromagnetic guided fenestration system, for example, a laser system, with a navigator that clearly shows the current position of surgical tools within the 3D model of the patient vascular system extracted from images acquired before the graft deployment. This video demonstrates the feasibility of the proposed concept. A traditional endograft was inserted into a model of abdominal aorta covering the renal artery origins. The navigation system has been used to guide a steerable catheter to the level of renal arteries. The simulated endoscopic view has been used to verify the alignment of the catheter axis with the one of the renal artery. Once having defined with precision where to perforate the endograft, a sensorized guide wire has been pushed against the endograft till to puncture it. The surgical procedure would be finished enlarging the perforation using, for example, a cutting balloon and deploying a stent graft to join the aortic component with a visceral vessel. In conclusion, no previous study has described a method allowing the real-time tracking of both catheters and guide wires, a fundamental step to avoid the need for live fluoroscopic images to perform endovascular interventions. At present, the Imperial College of London is evaluating the feasibility of an electromagnetic-based approach to endovascular navigation using the stealth station guidance system to display the position of the tip of a sensorized guide wire. However, results obtained by the same group suggest that, relying solely on the stealth station to track the guide wire, the performance of the operator is lower than using the traditional fluoroscopic guidance. The simultaneously tracking of both guide wire and catheter is in fact paramount for an optimal and safe execution of endovascular tasks and thus to achieve better outcomes.